Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you so much for joining us for our third and final session for the day. My name is Karen Cordero. I am the Director of Education and Support for the Adult Family Home Council. Today, for this final session, we are going to be talking about contracting with MCOs. And I am going to keep it short and sweet because you've heard the spiel so many times already. And I'm going to let the other presenters actually talk about the nitty-gritty of what we're doing here. And I'm just going to let you know that this webinar is worth 1 CEU, and those certificates will be emailed to you to the email address used to register for this webinar. You just want to make sure you stay online for the entire presentation. And with that said, I'm going to go ahead and turn it on over to Courtney. Courtney, thanks so much.
Thank you, Karen. Good afternoon, everyone. My name is Courtney Ward with Community Health Plan of Washington. Community Health Plan of Washington is one of the 5 managed care organizations operating in the state of Washington. You'll learn more about how to work with us in the next few slides. So just doing a quick intro to cover the content for today's training session. We will be walking through the differences between the core provider agreement, which is what you all as providers put in place through healthcare authority prior to contracting and credentialing with the managed care organizations. We will walk through the contracting and credentialing process and what to expect. We have a couple of timelines to showcase around the anticipated time it can take for contracting and credentialing. We're also going to get more into the meat of working with managed care organizations. So what you have to do in order to ensure appropriate claims payment, billing information that can go through, and some other helpful resources. And so I will turn it over now to my colleague from United, Miss Jen. If you want to take that that'd be great.
Thank you, Courtney. Good afternoon. My name is Jennifer Emery Morelli, and I'm the Director of Behavioral Health Provider Services for United. And today I'll be going over a very brief overview of the difference between your core provider agreement and your MCO contract. Next slide. So the core provider agreement is how providers get recognized by the HCA as being a Medicaid provider. And your core provider agreement serves as the contract between you and the HCA, and this covers then clients in a fee-for-service program. Really important, as Courtney highlighted in her intro, the CPA, the core provider agreement, must be in place for the MCOs to initiate the contracting process with the providers. And this is based upon federal rules. So your MCO contracting and credentialing, it's important to note that you have a choice to contract with any or all MCOs, and that your contracts with the MCOs may be very similar, but they could vary. So you want to make sure that you're reviewing those contracts from the different MCOs. It's important to note that for this program, providers not already contracted under the MCOs, again, we have streamlined contracts, we have streamlined forms, and we streamlined the billing as much as possible. But with that being said, there may be some nuances between the 5 MCOs. Also important to note that credentialing is an integral part of the MCO's contracting process. So in addition to the contract, to signing that and having it executed, we will also be requesting certain documents that we need in order to complete the credentialing process. Because the contract and credentialing go together then to complete the contract package. And next slide. And I believe I'm handing it off to Danielle.
Hi, good afternoon. This is Danielle Polite with United Healthcare. I'm a senior provider advocate on the team. I'm going to be helping you learn about our credentialing and contracting process and what to expect. So the credentialing is the first step in the contracting process. Credentialing is our method of verifying that the healthcare professionals and facilities are certified and licensed. This process has multiple steps in the process and can take up to 90 days to complete. How to start the credentialing process? You're going to complete the MCO credentialing application with us and provide requested documents such as your current license, and it must be in Washington State, so I'll call that out. Must have current liability insurance, most recent survey, a W-9 form, and the roster and list of locations. Following the receipt of the application, the MCO credentialing specialist is going to reach out to you with anything that they have questions on or if they need additional information. Upon successful completion of the credentialing, an MCO credentialing representative will reach out to move forward with the contracting. Here's some important good to know items for our credentialing. One, it's time sensitive. Credentialing is a critical piece in ensuring that the go live readiness is there and that we're ready to have you initiated as a provider in our network. Failure to complete the credentialing early may result in downstream delays, such as access to our portal, provider loading issues, MCO system issues, claims testings, and payments. Multiple locations, credentialing applications must include each licensed location. If you have a new location, the new location must be credentialed with MCOs in a timely manner. Also note that MCOs should be notified of any location closures. For the credentialing process and inquiries, facility credentialing applications vary by each MCO. The credentialing materials and inquiries can be submitted to each MCO, and we've provided here each MCO's email box where that can be sent to. MCO contracting. So contracting upon completion of the credentialing, the MCO will draft a provider contract and release for provider review and approval. Once the contract is completed and signed, the provider will be loaded into our systems, which will allow the provider to continue with the onboarding activities, including new provider orientation, register for the portal access, and register for electronic fund transfers and electronic remittance advices. To become a participating provider with an MCO, you must have a fully executed contract. So your contract defines your relationship between you as a provider and an MCO, the payer of your provider services. The contract outlines obligations, compensations, references to policies and procedures. A contract specialist cannot walk you through the contracting process from initiation to full execution. Contracting can take time. Contracts can be reviewed and signed by a provider as quickly as 30 days or can take much longer. Once that contract is signed by the provider, an MCO will route for countersignature internally. Once complete, a full execution of the contract will be sent back to the provider and a provider profile will be built in your system.
Thanks, Danielle. This is Courtney again with CHPW. So we'll just go over the next couple slides here. So the transition to community behavioral health support services. This transition from behavioral health personal care is happening to align with the individual's annual care assessment. So we have this rolling effort of transitioning folks from BHPC over to this Medicaid covered CBHS benefit. So we have a cohort that's starting in July, folks' annual care assessments who are due in August will be working on in July, so on and so forth. So this will be a process throughout the next year of transitioning these members from the BHPC or MCO ETR funded service over to CBHS. This is happening to reduce the burden on providers, case managers at home and community services, healthcare authority, MCOs, everything. We didn't want to bottleneck the system by having everybody transition over at one time. So as I just said, the focus for right now for July 1st will be on those clients who have a care assessment end date between June and August. We as MCOs are focusing on contracting with providers who have members with care assessments due in that time frame. However, we are also looking at contracting with future providers as well. So our priority is in this first cohort, right, this June through August, but we are happy to start conversations and start the contracting process for providers who have members who aren't transitioning till later in the year or even into the first of 2025. There are a few areas of the state where MCOs may reach out even if you don't have a current client. So by federal regulations, we have to procure a statewide network. So we as managed care organizations have to have a contracted CBHS provider in every region of the state. So if an MCO reaches out to you and you don't currently have any BHPC, know that we still may want to partner with you and bring you into our network for potential new clients that may need this benefit. Every quarter, the MCOs are working on contracting with a group of providers, as I've indicated, based on that care assessment end date. And this contract will allow you to be ready to serve new clients when they discharge from hospital settings, or if you have new clients that come into your home's facilities. The next slide is just a nice illustration of the words that were on the previous slide. If I didn't say this in the beginning, this deck will be sent out to everyone who is on the call today, so you will have this as a resource document. But this gives you a nice idea of those assessment dates, right? There, we have June through August in this first cohort, so on and so forth, who we will need to bring into network by these time frames. Let me just read quickly to see if there's any point that I may have missed on this. The main point being that, yes, contracts need to be in place before an MCO can approve a CBHS authorization. So this is imperative to start the process by getting that core provider agreement through Healthcare Authority. Once that's in place, then MCOs are ready to hit the ground running and work with you on solidifying that contract for these services. And we could go to the next slide. Yeah, we have a short pause, and I know there's a couple questions in the chat, but I think what has worked best is for us to just save those to the end. But Karen, let me know if you see anything that is.
Yeah, thank you so much, Courtney. And let me take a look here. I guess this question actually is pretty apropos for this moment. It says, if we have already done the contracting or credentialing in place, is there anything needed to bill for an ESF daily rate directly?
Yeah, we may need to unpack that just a bit, because if you have a contract with Home and Community Services for your ESF daily rate, and somebody jump in here if I am speaking out of knowledge, that's going to be separate than what's going to be billed to the managed care organizations. So you will still have to have a contract with the managed care organization for billing of both IBSS and CBHS services.
Perfect. That was a great way to clarify that. All right. And we could save the rest of them for the end. That'd be great. Thanks. Thanks.
All right, my name's Carrie Bentley. I am the program manager at Molina Healthcare, and I'm going to take you through some of the introduction and basic information for billing with the MCOs. For this slide right here is reiterating and saying it just a little bit different way than what Courtney just went through in the previous slides. Beginning 7/1/2024, Home and Community Services will no longer have the authority to authorize or pay for your BHPC in a resident facility. And again, this is a rolling process over the next year, but starting 7/1, any new residents who are coming into your facilities or any current residents who have an annual care plan that is up for renewal between July 2024 and June 2025 will now need to go through the managed care organizations. They will not be authorized or paid for through health or home and community services. So we have an example in here. It just basically means if a current resident is receiving BHPC and their care assessment is due in November of 2024, the provider will continue to have BHPC authorized and paid through healthcare service or home and community services until November of 2024. So basically you have some leeway between now and November to get contracted with the MCO, because as of December 1st, those services need to be authorized and paid through either the HCA if it's a fee-for-service member, or the MCO if they're with a managed care organization. Personal care is still going to be authorized and paid through their existing channels. That will not change, and you will continue to claim those through Provider One. This changes just for the behavioral health personal care piece. Providers can continue to reach out to their assigned home and community service case manager for questions related to the authorized services, which are included but not limited to the RSW. Some key billing information, and this will go into a little bit more detail on how to check eligibility and where these come into in the next section. But when you're looking up eligibility for a member in Provider One, these are the names of the managed care organizations that you'll be looking for. If you need to bill an MCO, it will be referenced as one of these in this blue box on the right. If it does not have if Provider One does not show one of these in the blue box, that means it's a fee-for-service member, and you will need to bill the HCA directly. Clients receiving CBHS supportive supervision, providers will use the CBHS billing guide. So this is great to know if you have a CBHS versus an IBSS or an ILOS member. We have two different billing guides that you'll need to look at depending on what services you're providing. It also is going to depend on your facility license type. So you'll need to pay attention to your license type for the facility, as well as what kind of services you are providing to make sure you're using the correct billing guide. The billing process for adult family homes. So there are some differences and nuances between how the adult family homes will bill versus the ALS and the ESFs. Adult family homes, there's been an agreement with the Adult Family Home Council to use a spreadsheet to submit claims to the MCOs for payment. The spreadsheet has been agreed on with the council, with the HCA, and also with the MCOs. And we'll go through this a little bit later too in detail, but basically there's a tab in the spreadsheet that gives you a directory of the fields. So what all the fields are, what data is expected in each of those fields, and you need to fill out all of those fields in order for us to actually be able to pay the claim. If it is a CBHS service, there is a tab at the bottom with each of the tier numbers in it. Those will be the ones that you would use for CBHS. If it is an ILOS, IBSS service, you'll be using the ILOS tabs. Again, we'll go over that in a little bit in another section. MCOs will convert the information submitted from the spreadsheets into their claims systems. So we all have it, all of our MCOs have different claims billing systems, and the HCA is requesting this information to be submitted to them. So we need to enter it into our systems to get it sent out to the HCA. And this information in the spreadsheet is what is pertinent for us to be able to send that data over. One big key piece to this is the spreadsheet billing is a temporary solution. The HCA is in the process of setting up a clearinghouse option for the adult family homes. It's just not ready yet. We have some funding things that we're working through, or that they're working through. And as soon as the clearinghouse is up and running, the adult family homes will get some training, and they'll be able to submit directly to that solution versus using the spreadsheet. For the assisted living facilities, enhanced service facilities, you guys are going to be using a clearinghouse. Well, you have a couple of options as well. So you are able to use a clearinghouse, which is an electronic format that will send all of your claims in a batch file to the respective MCOs. If you don't currently have a clearinghouse, all of the MCOs have claims portals that you can register for and log into and enter your claims data into the portals directly. All of the MCOs will have additional training on this. So depending on if your member is with Molina or United, our provider representatives will help you get registered and work through all of those once you get your contracting signed with each of the respective MCOs. The definition of a clearinghouse, this gets a little technical, but it may be helpful for those of you who are going the clearinghouse route. The clearinghouse is a trading partner securely transmitting claims, which is an 837 file, electronically from the provider to the MCO. Some of the benefits, it's a batch system, like I said before, so you can submit multiple claims to a single payer at once versus having to manually enter each member's claims for each date of service. You will get electronic remittance advice, or an ERA, that automatically updates on payments and any adjustments depending on the MCO information that you're getting back in your claims. They are all HIPAA compliant standards. It's a standalone entity, so it's a third party, basically. The clearinghouse will scrub your claims for errors prior to submission to the MCO. There's, again, another section later on, we'll be talking about what a clean claim is versus a non-clean claim. The clearinghouse will help get the clean claim submitted the first time versus having any back and forth interactions with the MCOs. The most common EDI transactions are an 837, a 277, a 999, and an 835. It's a lot of numbers. If you really are interested in what those are, you can Google them and they can give you a little bit more details of what those mean and what they do. It also allows the providers to manage claim status in one place. So if you want to know how many of your claims have been accepted or paid, or what the check numbers, things like that, you can find through a clearinghouse if you choose to yield that route. And I'm going to pass it off to Jamie to take the rest of these slides.
Hi, this is Jamie with Molina Healthcare, and I'm the manager of the Provider Claims and Appeals and Grievances Department. First of all, just rules around claims and timely filing. First, by federal law, we are only allowed to pay clean claims. A clean claim means that we receive the claim containing all the required data elements that can be processed without obtaining additional information from the provider regarding the service or potentially anything from a third party. You can refer to each of the MCO's provider manual for requirements for clean claim form submissions. A non-clean claim means the claim was missing information or had incorrect information that would prevent it from being moved forward and processing into one of our claims processing system. An example of this would be either the wrong member ID number or invalid CPT, ICD diagnosis codes, etc. Please note, MCOs are not allowed to alter any of this information on the claim. Therefore, we are not able to make any of those corrections needed ourselves, and it would go back to the provider, submit corrections as appropriate. For providers using the spreadsheet of the adult family homes, the spreadsheet will serve as a claim-like submission for services rendered. Again, so there are two main reasons of the MCO or HCA may deny a claim. One would be a rejected claim. This would be one of those non-clean claims that prevented us from moving forward and having the claim processed in the system. Or we could have a denied claim. This is when a clean claim is received and able to move forward for processing. However, still may be denied payment for various reasons. One example of a reason a claim could deny would be a change in the person's eligibility on the date of service being billed. When this happens, For providers using the spreadsheet template to bill, you will receive a notification of the reasoning for the rejection or denial. For the MCOs, that notification could be received via email or letter, depending on the different MCO. If you are using a clearinghouse, there are reports that can be requested that will indicate rejected claims and denied claims. Providers will need to work through these reports regularly to resolve any issues and be able to resubmit corrected claims when appropriate. Okay, timely filing of claims. Timely filing is the number of days when the MCO receives a clean claim and from a provider from the date of service. The amount of time you have to file a clean claim is dependent on your specific contract terms for each MCO. However, for the CBHS services, new provider contracts will have the 365 days, which means that 365 days is the time limit from when the date of service initiated. Claims not received within the required timeframes will be denied and not paid unless there's an extenuating circumstance, which may vary. Contract providers do have 24 months, though, from the original date the claim processed to either appeal the decision of the claim if you disagree with any potential denials, or send a corrected claim if needed for additional review. Reminders, please verify a client's eligibility for the dates of service. This will help ensure timely billing. And then that claim that do rejects, meaning not assigned a specific claim number, these are not clean claims. So these do not count towards that timely filing calculations. And I believe I'm handing it off. Thank you.
Hi, good afternoon. Erin Gillen with Community Health Plan of Washington, and I'm going to talk about monthly enrollment, understanding when, why, and how to check eligibility. Why is it important to confirm client eligibility to the MCO for CBHS? Not frequently, but at times a client may change managed care organizations. This can happen if the individual or their authorized representative requests a change. Sometimes clients will change plans because of a specific medical provider to be able to continue to see them. Your client may not tell you that they've changed plans, in which case, if you're not aware, you may accidentally bill the wrong MCO. A prior authorization from a previous MCO are required to be honored for only 60 days by the new MCO. Billing the correct MCO will ensure prompt payment rather than back and forth. And sending information to the wrong MCO is a HIPAA privacy violation. So double check eligibility. The Healthcare Authority updates eligibility each day, and providers should, at a minimum, check eligibility before they submit their spreadsheet or billing through a clearinghouse. This is true for both community behavioral health support and in lieu of services, IBSS. How to check member eligibility? To confirm a member's eligibility, go to the Healthcare Authority Provider One website listed here. For help, they have an eligibility manual that walks through each step of that process. To check eligibility using Provider One, you can determine Medicaid coverage in Provider One, and there are two steps to determine this. The first is to determine if the client is enrolled in Apple Health Medicaid. And if they are, does the client have an Apple Health Medicaid managed care plan? Please note that Apple Health Medicaid fee-for-service coverage is also known as coverage without a managed care plan. This means that the Apple Health Medicaid fee-for-service coverage is shown by a yes to question 1 above and a no to question 2 above. Okay, to determine if a client is currently in Apple Health Medicaid, there are several steps. First, you log in to Provider One and go to the benefit inquiry screen. Second, enter the client's Provider One identification number. Next, in the client eligibility spans area of Apple Health Client Eligibility Provider One webpage, you will need to confirm that there's active coverage. You can do this by sorting the eligibility end date, clicking the down caret in blue here with the highest value at the top. Finally, the client is eligible if the eligibility end date is 12/31 of 29.99, or the eligibility end date is the current month's end date, which means coverage may end at the end of that current month. Once you've determined Medicaid eligibility, you'll need to see if the client has a managed care plan. First, go to the managed care information section, and next sort by the end date, clicking the down caret. If one of the names in the blue box to the right is listed under the column Plan PCCM name, the client has managed care with that plan. Please note that if none of the MCOs are listed in the Plan PCCM name, or it lists just PCCM or HH, that means the client does not have a managed care plan, and you will need to work directly with the healthcare authority for those clients. Again, the acronyms are in the blue box that correspond with the plan names. What happens, or what do you see if a client is ineligible? You will see the red box won't be there, but it will say eligibility or benefit information code 6 inactive after you run a benefit inquiry. And that means that the client is ineligible and that their Medicaid is inactive. If that's the case, then reach out to their financial worker at Home and Community Services to determine if there's missing paperwork or documentation that can help with reactivating that, or if there's additional needs or information that can be submitted. All right, and I will pass it off to the next presenter.
Thank you and good afternoon. This is Audrey Silliman. I am the Director of Provider Relations with Molina Healthcare, and I'm going to go into a little bit more detail around how to bill and then payment. So in general, there are some high-level categories that, regardless if you're going to be billing using the spreadsheet or you're going to be billing either using a portal or a clearinghouse, there are some general categories of information that you're going to be capturing when you do bill an MCO. And that is provider information, so that would look like provider name, NPI, and taxonomy. Client information, so client name, date of birth, and their client ID. Diagnosis codes, service date, service provided, and then the amount of services. And again, just to reiterate, this is at a high level. Whether you use a clearinghouse or the spreadsheet, will be capturing that same information. And if we can open up the spreadsheet, I'm actually going to briefly hand it back to my colleague, Carrie Bentley, to walk through the template spreadsheet at a high level.
Hello again. So I brought this up a little earlier when I was talking in the introduction to billing section. This is an example of what the spreadsheet will look like for those of the AFHs that are going to be using the spreadsheet. As you can see in the Excel, there's multiple tabs down here at the bottom. There's the data dictionary that's in white, then the tier 1, 2, 3, 4, 5, 6 in green, which are used for the CBHS services, and then the ILOS, IBSS services are in blue that say ILOS with the 1, 2, 3, 4, 5, 6. The numbers indicate which tier level that you've been approved for with your auth. So this just shows you which template, which service, and which tab you're going to use for billing. The data dictionary is also what I commented that will give you the definition of what is needed in each of the fields in the actual tier tabs. So Audrey mentioned basic provider information, so your name or the provider name, your NPI or API. I'm going to pause just for a second and reiterate how important the CPA is. So if you do not have your CPA submitted to the state HCA, you will not have one of these. You won't have an API or have it registered with the state. And we, as the MCOs, we cannot pay you until you have at least the CPA submitted. So I just want to reiterate and push to get that CPA submitted as soon as possible. So at least that's not a barrier to any of services being rendered. Moving on, so you also need your provider taxonomy, the billing, street and address, city, state, zip code, the claim amount that's going to be billed. This gets into the actual claim data. So what services you are authorized for by the MCO or the HCA if it was a fee-for-service member. So they will give you the billed amount, your service code, which for all of these services actually is the S5126, so that should be pretty easy. And depending on which tier you have, there's modifiers that need to be billed with that service code. So there's a field for entering either one or two of the modifiers, depending again on which service is being billed. And then the number of units. So in this case, it's going to be one. And the spreadsheet has multiple lines. So if you're billing for a month, you can put 30 lines on it with 1 unit and bill it for a month at one shot versus doing one spreadsheet each day. And then we get into the patient or the client information. So where is the client staying? So if you have multiple residences that you're managing, make sure that we have that, put the address that that particular patient or client is at. Address, city, state, zip, typical information. Place of service, this is something that we need from a billing perspective that needs to go on the claim. Common places of service are 13, 14, and 33, and these are the descriptions that CMS uses. So that just needs to be entered into that field for place of service. The client ID is the provider one ID. So as it was just explained, going through how to find a member in provider one, this is the number that's assigned to them for Medicaid. So if you're not familiar with that, it's almost always, it is a 9-digit number with WA at the end of it. So we need to have that information to make sure we're getting the right member. And it's just another piece of validation for, again, making sure we've got the right member. The client's last name, first name, gender, date of birth. So this is all of our patient information that we need. And then the diagnosis code is also should be given to you, I believe, at with the authorization, or if not, from the transferring facility. So we need to make sure that that's in there. That's also an integral piece of the claim process and the data that's required. You don't have a valid diagnosis code, it will not be a clean claim. It will come back as a non-clean and will need updated. And then, of course, last but not least, the service date. So you need to just put the date. Since it is a unit of one, each service date will be a single date. It's not going to be a range. If you want to, if you can click into one of the spreadsheets, this is just how it looks when you're going to get the template from the providers or from the MCOs, I'm sorry. And as you can see, column or row 1 matches the different descriptions that were in the data dictionary. So you would just make sure to put the appropriate information in the appropriate column when you send it over to us. And please make sure that all of the fields are filled in. Again, this gets back to the clean claim. If we don't have all the information, it's going to delay payment because we're going to have to do some back and forth to you guys to make sure that we have all the information we need in order to process the claim correctly. Back to you, Audrey.
Thank you, Carrie. So for those of you that will be billing via spreadsheet, you'll need to make sure that you submit your spreadsheet to the correct MCO based on where the client is assigned. We each have designated email addresses where these spreadsheets can be submitted. I recommend printing this out, having it as a reference so that you, when you do, when it is time to bill, that you get your spreadsheet to the right place for processing. For those of you that will not be billing using a spreadsheet, here is some really helpful information. So for all 5 MCOs, we all use, I think we mostly use different clearinghouses. So if you are going to be submitting claims via a clearinghouse, I'll direct your attention to the second column here, payer IDs. You'll want to make sure that your clearinghouse is pointed to the appropriate clearinghouse so that we can accept that 837 file and process your claims. So go ahead and reference the payer IDs listed here and get your clearinghouse pointed to the correct location. If you have any challenges with clearinghouse transmissions, each of the MCOs have contact information that you can reach out to in order to get technical assistance related to clearinghouse transmissions specifically. And then finally, the last column of this table are the addresses where in the event you need to remit a paper claim, these are the addresses where paper claims can be sent. All right, next up, we will talk about payment timeframes and options. So just to lead off, I think this is an important statement. There are no restrictions on how often providers can bill the MCO. The cadence of claim submission is up to the provider. So you can bill weekly, monthly. I recommend probably billing at least monthly, if not more frequently, particularly if you have a high volume of clients that you're seeing, just to ensure that if there are any issues, we're addressing them in a timely fashion and you've got consistent revenue flow. But that's going to vary provider to provider, and I think everyone will kind of find a pace that works well for them. Most clean claims are paid within 30 days of receipt. So again, clean claim means that that spreadsheet is filled out 100% accurately and doesn't need any additional modifications. Or if you are submitting through a clearinghouse, it means that the 837 file was able to get over to your MCO and you didn't get a rejection. So 30 days from receipt of clean claims is typically when claims are processed. For payment, providers have 2 options. The default is going to be paper checks, so there's no additional steps on your part that need to be taken if you want to be paid by paper check. I will just note that as you're engaging with the MCOs and getting credentialed and contracted, do make sure that you've got your mailing address accurate if you're going to get checks. I know I've seen instances before where maybe your mailing address is different than your physical address, or a small typo and an address means a check goes to the wrong place. So just double check that to ensure the payments get to you in a timely fashion. Electronic funds transfer is the other option, and I will say I think from most of the providers I've worked with, EFT is the preferred option. It's really fast, efficient. You get the funds directly deposited in your account, and it does tend to be a little bit quicker than paper checks. And we'll go into more details about EFT on some of the next slides. The next important reminder on this slide is that Medicaid has a lot of state and federal regulations in place. And so just as an important reminder, that balance billing a Medicaid member is not permitted unless very specifically the provider and the member have signed the HCA form 13-879, and that form needs to be signed in advance of services rendered. If you have more questions about balance billing, I recommend reaching out to one of the MCOs or to the healthcare authority. It's a big topic and we only have time to just kind of scratch the surface today, but wanted to put that reminder in there because it is an important part of Medicaid regulation. Thank you. Next slide. On this slide, we'll go into a little bit more detail on EFT as well as electronic remittance advice for those who are using clearinghouses. So EFTs, again, electronic funds transfer, this is the fastest way to get paid. It means you get paid through a direct deposit to your bank account. It's more timely and secure. No checks getting mailed to the wrong address if you have direct deposit, and you do receive notification upon payment. For those of you who will be submitting claims using a clearinghouse, you will have the option to get you will get an ERA. So you'll be able to download an 835 file This is the electronic transaction that provides claim payment information and documents for your EFT. This is really helpful for posting payments and doing sort of claims and payment reconciliation on your end. You'll also be able to have a historical explanation of payment lookup, and you can search by claim number, member name, and you can also create custom reports. So some advantages there of using a clearinghouse for those of you who will be using a clearinghouse. So here's a little bit more information on how to register for EFT and ERA. Just a quick note, providers must register with each MCO separately for electronic funds transfer. I will say in general, EFT is a pretty quick process to get set up. In my experience, it's maybe 10 to 15 minutes of time. And again, if you want that direct deposit, it may be worth that investment of time. This grid here will help you get connected to each of the MCO's vendors they use for electronic funds transfer. You've got a website link for each of them, as well as a contact phone number if you need some assistance getting set up. And I think a lot of the MCOs also have an email that you can reach out to get additional support in getting EFT set up. And in terms of what you need to prepare, if you are interested in getting signed up with EFT, you'll need your bank account information for direct deposit, either a voided check or a bank letter to verify bank account information, and then finally a copy of your practice's W-9 form. And I'll hand it back to Courtney. Thank you.
Thank you, everyone. The next slide is just a couple of helpful resources. Again, you'll be sent this deck. So there's the contact information for Healthcare Authority, as well as how to get in contact with each of the MCOs to start the contracting process. And we can just go straight into the Q&A for the last 10 minutes or so of the presentation.
Sounds great. Thanks so much, Courtney. And thanks, everyone. So the first question, I think, came in quite early in the presentation. So I believe it's been covered, but I'm going to go ahead and say it anyway, or read it anyway. And it says, so once we've, so once we sign up and have an application or go through the application process through Provider One, are we to then apply with each MCO?
Yes, I think that question is indicating once you have gone through the core provider agreement process with the Healthcare Authority, you are then deemed a Medicaid eligible provider and would start the contracting process with each individual managed care organization.
Perfect, thank you. And the next question, what can a provider do if they do not have a current survey or an inspection and the MCO needs one?
Do we have someone from Home and Community Services on that could help us with that? Is there someone somewhere they could go to get another copy of it?
Let me see.
You could contact Residential Care Services, or those are available online.
So if they have just their initial inspection, that should suffice, is that correct?
That's correct. Residential Care Services should be able to provide that.
Great. All right. Are the residents in different programs, such as PACE, the PACE program, can they also have access to CBHS and IBSS?
IBSS would be no. Anyone correct me if I'm wrong, because that is not a managed care plan. And I think we'll need to get back to you on the CBHS if we could do that, then fee for service.
Says I have a client who is on CBHS according to the social worker, but he is not actively receiving services, but could possibly in the future. So should I go ahead and sign up with do the core provider agreement and contract with the MCO as well?
That one might, oh, go ahead.
Yeah, sorry, Jess. If you have a client who's on behavioral health personal care, I'm getting a little hung up on what the client is receiving today. However, if you think you have members who are potential or you would like to serve members with this benefit, then yes, going through the core provider agreement and then contracting with the managed care organizations would be a good idea. And Jess, I don't know if you had a different response.
No.
Okay. And the next question is, where do we get the diagnosis codes?
We're working on an internal process to be able to get you the diagnosis codes as part of some backup documentation when you get the care reassessment. And there will be a field on there for you to get that diagnosis code off of.
Great. So the next question is, direct deposit to the provider's account acceptable?
Yes. I believe providers are able to select their bank account of choice when they enroll with EFT.
Okay. If you have multiple residents and they don't know what what MCO plan they have, what is the easiest way to find out?
I would look back at these this slide deck here when we went over some of the enrollment. There's an easy way to go into Provider One. It's called Benefit Inquiry, and a couple slides back, it'll walk you through, and it'll show you, and you can check for each client so that they know.
Okay, thanks. So another question about that initial inspection or inspection reports. What should the providers ask from the initial licensing team? The initial inspectors do not leave behind any paperwork if they don't have any corrections to be made when an adult family home is first licensed.
I think that one may be one we need to get back to you on if our DSHS staff don't have an answer here.
Okay, thanks. So another question, it says, I'm still confused about contracting. We have contracts with all 5 MCOs, so we just are adding our ESF facility to it, or are we contracting and credentialing something entirely new?
And Jennifer, maybe I think that's Jennifer asking that, if I read my question correctly. If you want to let us know in the sorry, let me start again. If you want to put your email in the chat, we can give you a call and try to maybe work through your individual situation. Or if you want to call us or email, there we go. You gave it to me, so that that will work. We will email you and find a time to talk through that.
So another question, why did this change have to be implemented, and where we no longer will bill for the code through Provider One?
The reason that we had to do this change is because we were legislatively directed by state law to try to save the state money by by leveraging Medicaid dollars.
Okay, thanks. And I see Sarah here from DSHS was trying to unmute. And sorry, Sarah, I didn't see you in the attendee report or in the attendee list. And I can look at trying to promote you now, but we are, getting towards the end here. So next question. Can a client be eligible for both IBSS and CBHS?
No, because the eligibility, the diagnoses for the eligibility criteria would be different for each.
Great.
But the
Thanks for that.
service they get on either program, regardless of the diagnosis, is the same.
Okay. And I know we haven't talked about this at all, but the insurance requirements for MCOs, is it 500,000 and $1 million, or do they have to have higher limits?
We mirrored the insurance requirements that you already have so that you wouldn't need to do anything different.
Perfect. Great. Another question just came in. Is the amount of services, does that mean hours spent with the resident?
Yes, hours spent doing one-on-one care with the resident.
All right, perfect. I believe we've gone through all of the questions. If somebody sees one that I may have missed, please chime in. Feel free to chime in.
I think, did a new one just come through? Can new adult family homes participate? Is that new?
Oh, thank you. Yes. Can new AFHs participate in the MCOs? Thank you.
Yes, they would be able to participate after all of the other steps are done. So if it's a new adult family home altogether, or maybe adding a site, we would have to make the changes in provider one and then have those contracts in place.
Great. Okay. And then after billing, how long can an adult family home or a provider expect to wait to be paid?
MCOs, correct me if I'm not recalling correctly off the top of my head, but clean claims are in the contract required to be paid in 30 days. And that's why it's really important to make sure that those are clean and not missing any elements or anything, because if they are, those ones don't count towards that 30-day.
Okay. I'm not hearing anything different, so that's great. And actually, I remember this question came in at the end of the last session, so this is a great final question I think we have here. If the one-on-one hours differ in different weeks due to behavior fluctuations, would the rate of pay be different for the 2 weeks?
No. So here's where it gets a little bit tricky, because we had talked about averages across the week. The tiered rates are sort of in chunks. Like the first chunk is half an hour to 2 hours, and then 2.1 hours to I think 6 hours, and then 6.1 to etc. So if we see that the average is not in alignment with what you have authorized, after a couple weeks, we'll want to go back or you know, I don't know, not significant. You know, maybe 3-4 weeks, you're saying, hey, I'm either providing less or more. Maybe we need to consider redoing the tier. Does that make sense?
Yes. Yeah, that does make sense. Okay, well, I want to just be mindful of everybody's time. We are at 4 o'clock. Thank you all so much for presenting to our presenters, but also to our attendees. Thank you for taking so much time out of your day to spend these 3 hours with us if you were here for all 3 of them. Really appreciate it, and the great interaction, great questions. We will be getting the recordings out to you if you, and also the CE certificates. So thank you all, and I hope you have a wonderful rest of your day.
Thank you so much.